Hello everyone, I'm Reshma Roshania and I'll be presenting some research that we at Emory University conducted in collaboration with CARE India on the effects of early and repeat migration among circular migrant children in Bihar. Migration is a critical livelihood strategy undertaken by many rural households. The COVID pandemic really exposed the massive scale of temporary short-term migration or circular migration. It is estimated that there are around 100 million circular migrants in India. However, research on the health and nutrition of migrant children has thus far really focused on rural to urban permanent streams of migration. Circular migrants face disruptions to healthcare at home and barriers to services at their destination, which often is in poor working and living conditions. So our research really aims to explore this effect of repeated cyclical movement on nutrition among child circular migrants and how early age migration might interact with repeat migration. We focus in Bihar's brick industry. Bihar has among the worst nutrition outcomes and experiences the highest temporary movement in the country. And brick kilns are generally located in rural areas and are particularly hazardous. The brick industry recruits male to female pairs, which results in the presence of very young children on kilns who accompany their parents. We employed a stratified cluster sampling design and defined migrant households as those who reported being away from home for at least 60 days with at least one return home in the previous year and who migrated with a child under 3. We collected 2 rounds of data, one in the summer, which is towards the end of the migration season, and one in the winter, which is just a couple of months into the migration season. The analytical approach that we use is based on the UNICEF conceptual framework. So our migration exposures of interest are age at first migration, number of migration episodes, and duration of migration. And we hypothesize that these exposures are driven by the basic determinants and influence their underlying and immediate determinants, which then affect our primary outcomes of stunting and wasting. So looking at the origin of migrants in our sample, about half are from within Bihar and the remaining were from particular districts of other nearby states. We see that over half of migrant children were either born during migration or first migrated before 6 months of age. And about 45% of children experienced multiple migration episodes. There is a very high prevalence of open defecation on the kilns, almost 85%, and a very low interaction with frontline health workers during migration, about 5%, compared to 62% of children 12 to 23 months nationally who are fully immunized. Only 42% of children in our sample are. We also see a very high prevalence of ARI. Children who were born during migration were about half as likely to be fully immunized compared to children who first migrated after 1 year of age. And children who first migrated in early life were also more likely to experience illness. Stunting is particularly high, especially in the oldest group of 24 to 35 months, approximately 70%. And among females who first migrated early, those who experienced multiple migrations were more likely to be stunted compared to females who only migrated once, and this is not the case for males. Wasting in the summer is critically high, around 40%, and season was the strongest predictor of wasting, and for females, also diarrhea prevalence. So our study identified urgent programmatic needs for circular migrant children, for example, immunization and sanitation. These indicators lag far behind state and national levels, and this was the case even before COVID. Our results also suggest important gender differentials with respect to the effect of migration. We know that crisis exacerbates gender inequities, so an important policy implication is to adapt ongoing strategies to improve the status of the girl child, specifically for circular migrant households. Implementation of migrant-friendly policies includes better enforcement of existing legislation designed to protect migrants, as well as adaptation of current policies, such as inclusion of migrants in ICDS and portability of PDS benefits. Many recommendations have already been laid out previously, for example, in the report that I've listed here, and COVID has really pointed to the urgency with which these need to be implemented. Migration will not stop due to COVID, but it is possible that we will see an increase in this type of shorter distance, lesser risk within state migration in the future due to the immense distress faced by migrants during and after lockdown. Given the scale of migration in Bihar and the already existing poor nutrition outcomes, delivering multi-sectoral services to circular migrant families will be necessary to improve the overall nutrition picture. Thank you.